Hi, this is Ralph Cole, Senior Director of Federal Government Affairs at the American Association of Nurse Anesthetists. And I'm excited to be joined by an extremely talented panel to discuss everything CRNAs, what certified registered nurse anesthetists are, what we do, the value that we bring to the health delivery system. And I'm joined by a fantastic group of panelists, Dr. Randall Moore, the current CEO of the American Association of Nurse Anesthetists, became the Chief Executive of the AANA on September 5th, 2017. Prior to that, Randy served as a senior hospital administrator with Passavant Area Hospital Memorial Health System in Jacksonville, Illinois. In addition to Randy's hospital leadership experience, he has served as AANA Treasurer and Region 3 Director. In addition to his service to the AANA, Randy has had various leadership positions with the Illinois Association of Nurse Anesthetists, including being Region Director, Government Relations Chair, and President. Randy is retired from the Army Reserve after 22 years of military service. He has served in both the Illinois Army National Guard and Army Reserve as an infantryman, combat medic, and CRNA. In 2012, Randy deployed with a forward surgical team in Afghanistan, providing combat casualty care. Randy holds a doctorate in nursing practice from the University of Alabama, a master's degree in business administration from Southern Illinois University, a master's of science in nursing from Bradley University, and a bachelor's of science in nursing from Northern Illinois University. And all of this before turning 45. Good job, Randy. Catherine Jansky, president of the American Association of Nurse Anesthetists. Prior to her role as president, Ms. Jansky served the AANA Board of Directors as treasurer, vice president, and director of Region 5, as well as president of the Washington Association of Nurse Anesthetists and president-elect of the Colorado Association of Nurse Anesthetists. Currently, she is a staff anesthetist at Madison Street Surgery Center in Denver, Colorado. She also provides general, regional, and IV sedation anesthesia for ophthalmic surgery patients. Furthermore, Ms. Jansky served our country in the United States Air Force for 2 years and the United States Army as a nurse anesthetist for a combined 20 years of active and reserve duty, retiring in 2011 with the rank of Lieutenant Colonel. During her Army service, she deployed to austere locations in Saudi Arabia, Iraq, and Honduras, providing anesthesia support for active duty soldiers and the indigenous populations. A champion of clinical excellence, patient safety, advocacy, and technology, Catherine is serving as a continuous education chair for Colorado Association of Nurse Anesthetists. A CRNA for more than 30 years, Catherine graduated with honors with a Master's of Science in Anesthesia from the U.S. Army School of Anesthesia for Nursing Corps Officers, Academy of Health Sciences in Fort Sam Houston, Texas, and a Master's in Health Sciences from Texas Wesleyan University in Fort Worth, Texas. Her Bachelor's of Science in Nursing is from the University of Wisconsin in Madison, Wisconsin. Dr. Lorraine Jordan is the AANA's Chief Advocacy Officer and CEO of the AANA Foundation. She oversees the advocacy arm of the AANA, which includes federal government affairs, state government affairs, research and quality, practice, professional education, wellness, and the AANA's journal. Dr. Jordan is a CRNA and earned her degree from the Ohio State University. We're also joined by Dr. Jill Mason-Wynn, who's been a nurse since 1997 and a CRNA since 2002. Dr. Nguyen graduated from Northwestern University in Chicago, Illinois, earned her doctorate in nurse anesthesia practice in 2015, where she published her research and won the South Carolina CRNA Research Award. She is a Gulf War veteran from the United States Air Force stationed in Washington, D.C. She lives in Spartanburg, South Carolina with her husband and 3 kids. She's the president of the South Carolina Association of Nurse Anesthetists, who represent 1,350 CRNAs in the great state of South Carolina. She works as faculty at Texas Wesleyan University part-time and works at 2 surgery centers in South Carolina. Those surgery centers closed March 12th, 2020. And we're also joined by Dr. Michael Greco, who serves as the Assistant Vice President for Systems of Nurse Anesthesia Practice for Northwell Health in New York, the largest health system on the Northeast. Michael is as well an assistant professor of nursing in the Hofstra Northwell School of Nursing at Hofstra University. In Michael's primary role as assistant vice president, he oversees the CRNA operations in Northwell Health facilities in New York City, Long Island, and Westchester. Michael has been instrumental in deploying, reassigning, and recruiting CRNA teams during this COVID pandemic, as well as reassigning CRNAs to other areas in the health system that benefit from their advanced skill set. So welcome our panel. And with that, I'd love to hand it over to Dr. Randall Moore to kick us off.
Thank you, Ralph. Appreciate the introduction. So we talk about what's going on in healthcare right now with COVID-19 and the role that CRNAs play and the impact that it's having on the nurse anesthesia profession. It's important for us to highlight the fact that right now we have a significant number of our workforce has been redeployed out of the operating room, and now they're in ICUs all over this country taking care of critically ill COVID-19 patients. While CRNAs don't typically function in that capacity, it's extraordinary times call for extraordinary measures, and we're very proud of and very excited about the contributions nurse anesthetists are playing. The flip side of that, and it's a cruel dichotomy that exists with COVID-19, is that there's up to 50% of the CRNA workforce is underemployed or unemployed right now, like many other healthcare professionals. And we'll talk about that in the coming moments here, and why that's such a significant issue, and how we propose we can address that. The other piece of this is, with the cancellation of surgeries, clearly we have major concerns on the impact that that's going to have on healthcare institutions in this country, particularly rural America. And finally, as you well know, the status of personal protective equipment, also known as PPE, is still very concerning. And we talk to our members every day, and we're still hearing reports of our members and other healthcare professionals who have an inadequate supply of PPE. So with that, I'd like to send this to President Jansky so she can make some remarks.
As advanced practice nurses, CRNAs have a vast experience in critical care settings and advanced education and training in anesthesiology. CRNAs provide care across all settings and in all patient populations, and are the primary providers of anesthesia care in rural and underserved areas and on the battlefield in forward surgical teams. CRNAs are uniquely trained and positioned to be helpful during the COVID-19 pandemic. All CRNAs have at least 1 year of experience as an RN in a critical care setting, with an average CRNA having 3 years of this experience before entering into an educational program. Since the outbreak of COVID-19, CRNAs have continued to provide top-of-the-line anesthesia care, but they've also seen their roles change drastically. CRNAs' expertise in airway management, hemodynamic monitoring, management of patients on ventilators, placement of invasive lines, and overall management of critically ill patients uniquely positions them to provide life-saving care to those suffering from the novel coronavirus. While many providers, including certified registered nurse anesthetists, are on the front lines of dealing with COVID-19, many other CRNAs unfortunately find themselves with significantly reduced hours, furloughed, or even laid off.
I think a theme for us at AANA, from the president to the CEO to the everyone working at the AANA, is focused on personal protective equipment and the ability for our CRNAs, every other healthcare provider who's out there on the front lines, having access to adequate personal protective equipment. Dr. Jordan, I know you've recently overseen an internal member survey with our membership. Can you talk a little bit about that and what we found and what our members are seeing out there in the field?
Sure. Thanks, Ralph. Well, at the end of March, early April, we conducted a survey trying to assess the impact of COVID-19 as it relates to our members. We had a 20% response rate. That's really fantastic. Within that response rate, we covered several different topics. The one I want to really highlight here and now is the rescheduling of procedures, as well as some of the clinical practice challenges that our members are seeing. In particular, the personal protective equipment and ventilators, as well as additional critical care locations. 51% of the respondents indicated that their facility was seeking additional critical care locations to be able to combat and be prepared for COVID-19 patients. 43% of the facilities have expanded their bed capacity to be able to meet the needs of the anticipated number of patients being affected by COVID-19. The majority of our respondents indicated that they were had a shortage of the stock of PPE, such as N95 masks, reusable respirators, full face shields, goggles, and disposable gowns. 40% of the CRNAs didn't think that their facilities had enough adequate screening or testing capabilities as it relates to COVID-19. And most alarming, 87% were concerned about keeping their family safe during this pandemic.
Thank you, Dr. Jordan. And Michael, I know that you've been working on the front lines in New York State, dealing with many COVID patients and overseeing teams that are seeing a large number of COVID patients every day. Why don't you share with us a little bit about your experience on the front lines dealing with the crisis?
You know, Ralph, when this pandemic first started, I was actually sitting right here at my desk. And I remember one of the deputy executives running back and forth throughout the floor of our health system. And he was saying, you know, next week we're going to have a lot of cases here in New York. You've heard about cases on the West Coast, but who thought that they would come right here in our own city of New York City? And then the next day we heard there was one case out of Westchester. Well, everything from that point on is pretty much blur because we've seen a proliferation of cases throughout our entire health system. I've witnessed all of our units, our entire hospital basically becoming that of a COVID-19 hospital. My CRNAs, since we are in a role, a translational role, our CRNAs were immediately deployed as they were closing our operating rooms down for only per se elective cases, or no, per se emergency cases. And from that, my CRNAs, their translational skill set was immediately placed to where they needed us most, which was pretty much in the intensive care units and on COVID airway teams. So we first of all started with an airway team consisting of 2 CRNA clinicians. And since the numbers were so high that these CRNAs were getting called for almost 22, 30 intubations within 24 hours, we formed a second set of COVID airway teams, and then a third set of COVID airway teams, leading to 6 CRNA providers on the front line of securing the emergency airway for intubations. My other CRNAs went up to the ICU and demonstrated that our skill set as nurse anesthetists, like I said, is translational, where they were managing and prescribing sedation. They were still providing emergency airway management as needed in the unit. They were managing, prescribing different ventilator settings. They were consulting, they were rounding with the physicians, prescribing cardiovascular therapies. Really, they were just supporting other services that needed us. Our hospital just really turned into this COVID facility with every unit being that of critical care patients. And I got to really give a shout out to my CRNAs, especially Lenox Hill Hospital, Staten Island University Hospital, that really went to the front and really demonstrated to our administration what we as nurse anesthetists can do and what we do. We go to the front line, we accept the challenge, and we take our skill set to where they belong, at the front. And we did that.
Wow, thank you for that, Michael. That's inspiring. It makes me really proud to represent this great profession. And just a quick follow-up question: as you were doing all these amazing, highly skilled things to help combat the crisis, were you guys being supervised by physicians during that time?
We were not being supervised by physicians. We paired with our other advanced practice providers, nurse practitioners, physician assistants, and we all worked together to fill the void and that gap that was there, that staffing gap in the intensive care units, to manage those patients. So we were not directly supervised by any physician. We took our advanced skill set, like I said, and we just brought it to the front lines where we provided our independent practice, just like the governor wanted.
Amazing. And personally, I just want to say thank you and to all the New York CRNAs who've taken on the brunt of this, massive pandemic. So thank you, Michael. And that brings us to the current state of the CRNA workforce in America, one that we think is going to be critical not only during this crisis, but also serving in a critical role after after we start coming out, when we start coming out of the other side of this pandemic, and elective surgeries are on the books, and the need for healthcare remains, the critical role that we can play. Dr. Jordan, I know that our survey also looked at current employment status. Can you shed some insight into what we're seeing as far as our guys, current status in the workforce?
Sure. So one of the things that we wanted to know is, what effect did COVID-19, or what effect does COVID-19 have on employment status, furloughing or terminating our CRNAs in this country? Now, keep in mind that the data that I am presenting to you and the findings were collected as of the beginning of April. I'm anticipating that we've seen significant shifts in the data even since April. However, I will report to you what we saw at the beginning of April. 30% of our respondents saw no change in employment. 50% indicated they had experienced a significant reduction in hours. Of those, W-2 CRNAs reported 51% of the W-2 CRNAs actually have experienced a reduction in hours. And when we talk about the 1099 CRNAs, 43% indicated that they were furloughed, and 36% indicated a reduction in hours. That's a significant hit for our members to experience as COVID-19 has begun to creep into our healthcare system.
Wow, those numbers are truly alarming. And to shed a little bit of additional personal insight on this, Dr. Jill Mason-Wynn, could you share your current situation, a little bit about how you arose, how you wound up here, and what Congress, what policymakers could be doing to keep our anesthesia workforce whole throughout the duration of this crisis?
Thank you for having me. Well, back in March, about 6 weeks ago, all of our elective surgery centers closed, and we are what are 1099 contractors with these facilities. So there is no paid time off, there's no vacation time. If you don't work, you do not get paid. So I lost 100% of that income from those surgery centers. And when people think of elective surgeries, it's not just a colonoscopy or a nose job or something as such. It could be all the way up to a heart stent. So these are things that are planned, not emergent. And that's where we're really hurting. We have a calling to help people, and we want to be on the front lines like Dr. Greco, personnel in New York City, and some of our CRNAs in the state have left to go to New York City to help since we've been kind of pushed to the sideline.
Now you as in your situation, you are out of work currently, and I think from a policy perspective and coming out of this crisis, I think it's absolutely imperative that we take proactive steps, and that policymakers have the foresight to make decisions now that are going to ensure that on the back end of this crisis, our surgical capacity is where it needs to be to meet these procedures. Because as you highlighted, it's not all nose jobs and tummy tucks. There's heart stents that need to happen. And, as soon as we get elective surgeries back online, how fast are these facilities going to be able to rehire? Are you going to do you have an agreement with your facilities to go back to work there? Is there something in place currently to ensure that day one we're ready to go, that we have that capacity in place? Is there any agreement that you're with you, or is that commonplace for other CRNAs?
I don't have any agreement in writing. It all goes on that we used to work for you. Hopefully you will let us come back and work for you. And the backload of elective cases will just explode. And they will need people. And we are hoping with good faith that we get to come back to our jobs.
Yeah, absolutely. And that's why I think it's so imperative for Congress to make sure that, the critical healthcare workforce remains whole and remains financially whole throughout this crisis, and that there's some incentivization for facilities to hire folks at the rate that they were at prior to their interruption in employment. Because if we want to hit the ground running with providing the care that people have been waiting for and need, some of those things are going to have to be in place. So thanks so much for your story. And now we transition, to moving forward. What's next? What is the CRNA community? What are we seeing? What are we feeling? What are we thinking? How are we going to be involved in the current state of this crisis? How are we going to be involved moving forward? Would love to hear a little bit about from Dr. Moore, wearing both your CRNA hat, your MBA hat, and your CEO hat. What are the biggest challenges? Where are we headed? What role can CRNAs play in right now? With our unique skill set, but also the future challenges that are bound to arise from this crisis that we're dealing with right now.
Yeah, thank you, Ralph. Let's focus exclusively on healthcare, because there's a big conversation that needs to happen around some of these other macro factors, including the impact on the economy. But I think if we talk about what's going on in healthcare, clearly in the coming days and the coming weeks, and this is starting to happen a little bit already, is the elective surgeries are starting to come back online. And that's a good thing when it's safe to do elective surgery, and we're supportive of moving forward if certain criteria are met. So with hospitals experiencing somewhere around 70% of their revenue being adversely impacted by the cessation of elective surgeries, getting these procedures moving forward makes sense, but we want to do it safely. As we move forward with that, we'll see, I think, that in some communities, they'll resume elective surgeries, and then they'll have to stop because of increased numbers of patients who are COVID-19 positive in the communities. And that will occur as we start to reopen or attempt to reopen the communities in this country. So we need to be very cognizant of the fact that this will not be flipping a light switch on and all of a sudden elective surgeries are back to the way they were pre-COVID. It's going to be a slow trickle, which is the safest way to do it, obviously. So moving forward, we really need to be cognizant of the impact that this crisis is having on rural healthcare in this country. 170 hospitals have closed since 2006. Right now, there are 350 hospitals, most of which are rural, who are circling the drain financially. And this crisis could very much, could quite likely push some of those over the edge. So we need to be very cognizant of that. And I understand there's funding that's gone to the hospitals, and another $10 billion has been allocated for rural facilities, but we need to ensure those rural facilities, which are the lifeblood to those communities, remain open because if they disappear, then you create hospital deserts in this country, which really is not good for access to care. So as we talk about access to care, one of the things we need to be really focused on is the removal of barriers for the full utilization of nurse anesthetists and other non-physician advanced practice providers, especially in these rural and underserved areas. Whether it's in Washington, D.C. through payment policy or in the VA, or whether it's at the state level, we need to be really aggressive in that space because the access to care issues are not going to get better. In fact, they're going to get worse. So as we move forward and we look in our crystal ball, it's really important for us to understand COVID-19 and the ramifications of COVID-19 are going to be experienced by all of us for the foreseeable future. With that, I give it back to you, Ralph.
Yeah, thank you, Dr. Moore. And I think you touched on something that is imperative, I think, from a policy perspective. We've seen the federal government, this administration, Congress, governors all take steps to temporarily remove barriers to CRNAs and other advanced practice providers. I think that this is a positive step forward. What is the AANA doing to try to help ensure that policymakers understand? President Jansky would love to get your perspective on why this is so important, what you're hearing from our members, and just a little bit of a brief perspective on why you guys, CRNAs, each one of you are, I'm the only non-CRNA on this panel, but from your perspective, what do these barriers mean in real life, and why are they there, and why shouldn't they be there?
Thanks for that question, Ralph. I think that one of the biggest things that I experienced when I was coming out of the military was I wanted to go back to the VA and work, but I wasn't able to work with my full scope of practice of skills going back into that situation. So rather than go into an area where I didn't feel like I could give the best care to the patient because I would be unnecessarily restricted in my scope of practice, I chose to go work in another area. So I think that's one of the biggest areas I see the scope of practice as an issue, especially for people coming out of the military. The other thing is when you have more than one person doing the same anesthetic, you're paying more people than you need to do the same work. If we have the anesthesia care team, people work in a supervised area, but it doesn't need to be supervised to the extent that we're wasting taxpayer dollars or having people that are not doing their share of the work. So having removal of supervision will help to allow CRNAs to work to the full scope of their practice, and also decrease costs, increase access to care, especially in the rural areas, as we've heard, and make the profession much more able to contribute to the healthcare issues, especially after COVID-19, when we're coming back and we need to be as economical as possible. We need to control costs. CRNAs are part of the solution.
Excellent take, and that's I think very important for folks who are watching this and participating in this briefing to realize is that every branch of the military, Army, Navy, Air Force, combat support hospitals, and forward surgical teams all already allow the full practice authority of CRNAs, and the fact that the Department of Veterans Affairs, and President Jansky, thank you for bringing that up, because it's an issue of that's become pretty prominent right now here in DC. Is directive and associated memo from the Secretary of Veterans Affairs and the Chief Executive in charge, Dr. Stone, and an associated memo that urged facilities to recognize the full practice authority of CRNAs. I know this is an issue that we as an association have been dealing with for quite a while. Dr. Moore, as you're unique, that both you and President Jansky have a unique perspective here. Would love to get your take kind of on the current situation in the Department of Veterans Affairs and what you think the VA should be doing as far as anesthesia policy to improve access for our veterans.
Yeah, it's interesting that to watch this play out, and I'll be honest, sometimes quite frustrating, because as a veteran who took care of veterans and who was forward deployed and was involved in the care of veterans who were profoundly injured in some cases, it shows to me that I can take care of a patient who's profoundly injured in a combat zone, but if I come back into the United States and I work in a VA or in some VAs, I'm being directly supervised by a physician anesthesiologist while doing a cataract surgery. And it just doesn't make any sense in any world, under any situation, right? If you look at our veterans, what they need is access to care, and what the system needs is cost-effective care. And so, these antiquated staffing models, which are really built on bureaucracy and politics, to be perfectly candid, are actually harming people. So this is not just theoretical. This is not just having conversations about, turf battles between CRNAs and anesthesiologists. This is about access to care. And we have clear data that, surgeries are being delayed, procedures are being delayed, veterans are being harmed. Because some people are playing politics. And now is past due the time for us to do the right thing, which is increase this access to care and fully leverage the skill sets of nurse anesthetists within the VA.
Thanks, Dr. Moore. And Dr. Jordan, since we have our resident research and fact-based expert sitting on the panel, I wanted to get your take, because there are opponents of full practice. And, from my perspective, their arguments against full practice aren't based in evidence. Being our guru for all things evidence-based, what's your take on the status of research as it pertains to anesthesia delivery in America?
Well, Ralph, there's a plethora of research out there to indicate that quality is not an issue, that cost savings would be significantly impacted within departments if we were able to practice as CRNAs using our full scope of practice and being able to apply everything we know, and we're able to use the skill set that we've been taught to do. The research is clear and concise on our ability to move forward as full practice authorities in anesthesia to provide anesthesia to this country as a whole. And I would suggest that we continue to rely on the evidence. The evidence and the economics will take us into tomorrow and will actually help prepare this healthcare system for tomorrow in a way that it is not prepared to move into today. So I would suggest that we move forward as CRNAs, continue to ask and promote the kind of practice that we are prepared to give Americans in this country.
Thank you, Dr. Jordan. And for those less versed in the details of research, I took from that because I say so is not an argument that has any real place in serious healthcare policy discussion, especially in this critical time. So we're just about to wrap up here. I wanted to go around the panel and give you a chance to tell the Hill anything you think they need to know right now. So let's start with Dr. Moore.
Well, first, I'm going to thank you for your time, and thank you for your contributions during an unprecedented health crisis, which is hopefully going to be behind us sometime in the near future. I think just the takeaway is for us is that, nurse anesthetists have stepped up. They are on the front lines taking care of these patients. And we think that now is the time to remove barriers at the state and national level. And we have a mountain of evidence to support that. And it's never been more important to be focused on increasing access and decreasing cost and increasing quality. And nurse anesthetists check all of those boxes.
Dr. Jansky, parting words.
I'd like to thank everyone that's watching this video, and you'll have information on how to get in touch with us. Please ask any questions that you have. We have the answers for you. I'd like to thank you for everything you've been doing to try to help healthcare providers during this difficult time with COVID. It's been difficult for everyone, you as well, in terms of how to economically help the country stay alive while we're all sheltering at home. So I'd like to thank you for that. In terms of the temporary relaxation of the supervision during COVID, it doesn't make sense to go back to something that once we show that works, it doesn't make sense to go back to a model that is more expensive and has now been not only shown through research, but shown through practice that it's viable, it works, that we can do the job. Why should we spend more money doing it a different way, an antiquated way? Thank you very much.
Dr. Jordan.
Thank you for allowing us to at least begin to address our concerns and bring those forward to you. We are here to solve today's problems. We are here and we are the answer, and we are on the front lines helping to address and care for those patients who've been affected by COVID-19. We want to do our best, not only today, but in the future, to serve this country and move the healthcare system into a much more nimble system. Please allow us to do that. Support us as we want to support you and our citizens in this country to make healthcare much more viable for everyone. Thank you again for listening. I very much appreciate your time and effort.
Okay, so I've asked Dr. Jordan, President Jansky, and CEO Moore their final questions. Now I want to give it, give the mic over to you guys to, let legislators, let staff members, let the decision makers around healthcare policy know what's the one thing that you as a practitioner who's been affected by this, Dr. Mason Wynn, what do you think folks need to know to ensure that we have the healthcare system that every American deserves coming out of this crisis?
Well, what we've learned is our skills are invaluable, whether we're on the front line or doing elective surgeries. And I would plead that our legislators and South Carolina Hospital Association and other hospital associations look at their bottom line right now. They need to be utilizing all healthcare providers to their full scope of practice, education, certification, and licensure, especially when they've lost millions in just 6 weeks of dollars. And I would say that we have a proven record. CRNAs are safe, and we have research that backs up. We are the most cost-effective anesthesia business model. And I would implore them to take a look at that and utilize it the best way they can, because that's what our citizens need, and that's what the country needs right now.
Thanks, that's great. And Dr. Greco.
We have demonstrated our reliability. We have demonstrated our advanced skill set. We have demonstrated that we are there and that we are able to provide when the country needs us most. Once Governor Cuomo released and gave us full practice authority, we were there. We were the ones that took the ownership of the role, and we ran with it and provided top-notch service and care when our patients needed us most. So what I'd like to see come out of it is, if we were good to do it during the pandemic and we were successful and administration recognized and noticed our expertise, well, then we should be able to do that any other time. And I'd like to see that continue for our patients, especially now that the workload is getting there.
Thank you, Dr. Greco. And my only parting words, and I think what we've highlighted and illustrated today, is that CRNAs have been asked to provide the highest quality healthcare on the front lines of the battlefield since the Civil War, up into the front lines of this crisis that we're facing today. And in all those instances, they've been utilized to provide the highest quality anesthesia and related services across the board, and to have policies in place that impede their ability to meet the demands of a crisis, meet the demands of our soldiers on the front lines. It's about time that we remove these barriers that aren't based in science, aren't based in evidence. We live in a science-based, evidence-driven world of healthcare, and to deny the evidence and the economics is to the detriment of patients across the country and to the future viability of the healthcare delivery system. We here at the AANA stand ready to answer any questions you have, provide any of the research or evidence that you may need. So please feel free to reach out to me at info@aanadc.com. We'll be sure to get back to you promptly with any information you request, or to have a follow-up conversation to walk through some of the issues that we talked about today. With that, I'll say thank you to the panel, and thank you all that have tuned in. Thanks.